Okay, we've seen these pictures, so we all know what we're talking about, and it all looks very attractive. But these are the concerns that people have, and Chris has just enumerated them, but I think it's important just to go over them again. Is there a need for peripheral cannulation? That's something to be considered. Bypass times have tended to be higher. I'm sure with more experience they come down, but these are the data. The ischemic time tends to be longer, and assessing the heart is virtually impossible, but you might say it can all be done by the TOE. Other concerns, it's more complicated to remove air. It can be done, of course, with TOE help and so on. It's a lot simpler here. Not much difference between post-operative atrial fibrillation. And you might say, so what? Well, there is a small instance of stroke associated with post-op AF, the order of 1-2% perhaps. And there is less bleeding, I quite agree, with minimal AVR. But we've got to be sure there really is less bleeding, because the experience of some people going back into patients who've had a mini AVR is that there has been very significant bleeding, but no one's done anything about it. And the heart is really encased in adhesions. So I think we're a little bit careful there. And depending on how you do it, there is a potential for damage to the right internal mammary artery. And in terms of recovery, yes, a few more days. It's interesting that despite all the studies, I was expecting when this first came in, I don't know, 15 years ago, and I did quite a few myself, that we would see much better recovery from the respiratory point of view, because you're not interfering either with the rectus abdominis or the fibers of the external oblique. But this data doesn't seem to have appeared, or maybe people haven't bothered to look at it. Yes, of course, there is more wound pain with a full sternotomy, and therefore there's more narcotic use. And mini AVR may be more cosmetic. I think it depends a lot how high the incision is. I've always tried to do a sternotomy so that with 1 or 2 buttons of your shirt undone, it's impossible to see you've had an operation. So when you go and have a job, apply for a job, if someone sees a scar there, they'll find a reason not to give you the job. And I think it behoves us to remember that with patients. The minimal invasive operations I've seen of AVR, the incisions are quite high, but I'm sure it doesn't have to be like that. And therefore, to me, not very cosmetic at all, especially in women. So Barry Matuza, when he was with us, did this meta-analysis, and they asked the question, does minimal access AVR actually reduce AF? And found that, as I said earlier, no significant distance from a fairly long list of studies. Some of them quite small, but some of them 176, 100, 100, 232. Now, my colleague Shiraz Raja works at Harefield. He's very keen on full sternotomy with a limited skin incision, and recently 78 patients, no mortality, 1 stroke, however. Length of stay 4 to 18, median 7 days. No peripheral cannulation, conversion is simple if required, and no need for special kit. Now, just looking at these slides, or these papers rather, comparing conventional with minimal invasive, here's a prospective RCT. I've just been looking at the RCTs and the meta-analyses in 2002, a little while ago. Dogan, minimal invasive versus conventional in Journal of Heart Valve Disease, and Barry Matuza, I think I wrote with him, is it worth it? This was a meta-analysis, slightly different from the AF meta-analysis. So no real superiority over conventional AVR. I appreciate that's a little bit dated. Now, if we look at the Merck paper again, yes, this is encouraging. 2,051 patients with propensity matched comparison down to 954, so it's equal numbers, mostly in their late 60s and 70s. Logistic Euro score is significantly higher, and these are the points that Chris has already made. So the minimal invasive was being saved for the lower risk patients. Cross-clamp times very similar. Intra-aortic balloon pump use a little bit greater, well, significantly greater in the conventional group. And the in-hospital mortality higher, than in minimal invasive. Reoperative for bleeding, interestingly higher here, which surprised me. And 5-year survival better in the minimal invasive group. So are we saying there's a slightly riskier operation up front, but you get better medium-term results? I don't think so. I would just take you up on sutureless valves. I'm still not convinced, watching some of the results of sutureless valves, that you've actually got over the paravalvular leak problem. I know in the world of TAVI, paravalvular leak is just something you shrug off. But actually, paravalvular leak, when I was training to do aortic valve surgery, was something you avoided like the plague. And if you had one as a new consultant, you had a lot of queer looks for the next month and no more patients referred. But suddenly it's become all right because it doesn't involve an operation, I suppose. So here's a more up-to-date review, mini sternotomy versus full sternotomy with a sutureless bioprosthesis. And here's the mini sternotomy, the full sternotomy, similar, bypass time slightly longer here. And 2 patients died in that group, small numbers, of course, and similar length of stay. So what was interesting in the discussion of this paper was that the adverse events were more frequent in the mini sternotomy group. And these adverse events involve repositioning the prosthesis, intraoperative dislodgement, having to convert to the conventional operation, paravalvular regurgitation, and the need for a pacemaker. So this is recent work. Whoop. Right. And then if we look at reoperative, and I quite agree, I am very impressed with Larry Cohn and his colleagues' study, and they've been using this for reoperative AVR for a long time. The majority of patients have had previous coronary surgery with a patent lemma, and they now need an aortic valve replacement. It's not actually redo aortic valve replacement. It's redo sternotomy. That's the majority of that series. And if we look at the relative risk of in-hospital mortality, well, we're sitting over on the line of identity. And if we look at the relative risk of perioperative stroke, again, we're looking sitting on the line of identity between favoring mini-invasive or favoring conventional. So actually, no significant difference. So you may plead non-inferiority, but if you're going to make progress and get this thing adopted and convince authorities like NICE, you've actually got to show superiority, I think. Minimally invasive AVR, it needs considerable expertise in conventional AVR before you start off doing it, and then you need adequate case volumes. Christopher's already said that. And it's absolutely essential, a team approach. You need very good echo support, and you need everyone understanding what you're trying to get at. But one of the gripes I would have about the information so far is that you haven't standardized the procedure. And one person's minimal AVR is not the same as another's. There are groups of people who are very keen on a small right anterior thoracotomy or different kinds of hemisternotomy, going to the right or going to the left. So I think what I'm looking forward to hearing about is an RCT either versus conventional AVR or with a sutureless valve versus TAVI. And I think that would be the really interesting study, to put TAVI versus sutureless valve with minimal AVR. And then that might be a very interesting result, because you ought to have less paravalvular leak and you ought to have less embolic risk. So I think at that point, thank you for bearing with my voice. Thank you for listening.